Okay, so we're going to continue on our journey into microbiology and infectious disease and all the antibiotics. Any questions from the first section? I've had a few that came up in between. One thing that came to mind that's of good to note, I talk a lot about things that may or may not have staph coverage, like when we talked about like our penicillins and whatnot. It's important to note that I'm usually talking about Staph aureus there, right? So when I'm saying that, you know, your aminopenicillins don't have any staph coverage, I'm talking about Staph aureus, so they don't cover MSSA. And then obviously if I'm talking about MRSA, I'll put that on there. So just so you guys are clear on that. Anything question-wise you have? Everyone's an expert on penicillins and cephalosporins. Fantastic. We're going to continue with our beta-lactams here with the Monobactams. This is probably one you're not going to see all that too often. This is really just a single drug kind of group, but it's important to note because it still falls in this beta-lactam category. And so this is as Trianam or as Exactam. You can still see the beta-lactam group there, so that's why it still fits in this category. And you guys remember what the mechanism of action of the beta-lactams are? Yeah, they prevent cell wall synthesis within the bacteria. You guys remember if they're bactericidal or bacteriostatic? Bactericidal, right? Because when you inhibit that wall and you have a big hole in it and all the contents come spilling out, that's pretty deadly. So yeah, definitely be bactericidal. So the monobactams are kind of interesting because as Trianam really only has coverage against gram-negative aerobes. So it's really the only thing it's going to be good for are gram-negative aerobes. But it's good to note here that it does have activity against Pseudomonas. So again, it's always good to note things that have activity against Pseudomonas. Good to note things that have activity against MRSA. This is going to be one that has good activity against Pseudomonas. But really no gram-positive activity to speak of, so it's fairly narrow spectrum for the most part. The thing that this really had its claim to fame is that patients who had, say, a true anaphylactic allergy to penicillins, there is almost no cross-reactivity here with these allergies. So, you know, back in the day, this is the one that you could absolutely give without any kind of reservation for someone who had a true anaphylactic allergy. Now, we talked about the allergies a little bit, and that's also a good point to note that, you know, you'll find some people who are a little bit more or less hesitant to give something like a cephalosporin to a patient with a true penicillin allergy. And again, it's always going to depend on what their experiences are. It's important to know that there's no right or wrong way to do it. But again, like I said, a lot of the things that I'll do when I'm trying to convince a provider to try something like a third-generation cephalosporin in someone who claims to have a penicillin allergy is just do a test dose while you're either in the office or the ER. That usually will give you your answer right there, right? Anywho, so notice this is still going to be one of the, would this be a concentration or a time-dependent killer? Based on how we're administering it. Yeah, it's going to be a time-dependent killer, right? So again, you want to keep it above the MIC for as long as possible. That's again why we're giving it every 8 hours here. Again, this is also renally eliminated, so you want to make sure you're checking for renal dysfunction in order to adjust the dose if you need to. And no real interesting things as far as like side effects go or anything like that, or monitoring. So very similar to what you see with like a lot of your penicillins. Then we have a little bit more interesting group. We have the carbapenems. Again, these are also going to be beta-lactams. You see here we have imipenem, which is oftentimes put with another drug called Cilistatin. We'll talk about that in a second. And you also have meropenem, ertapenem, and doripenem. So 4 drugs that fall into the carbapenem group. Now, I like to call these gorillacillins because they have really good activity. They kill a lot of stuff. They have really good gram-negative activity, including Pseudomonas, with one notable exception. Ertapenem does not cover Pseudomonas. That'd be good to know. And then it also has good anaerobic coverage and some decent gram-positive coverage. So this really treats a huge swath of things. No MRSA coverage, though. And they are, in general, very resistant to beta-lactamases. So these are really good drugs to go to if you have really resistant bugs that are growing. These are not ones you want to go to first line for a lot of cases because of the fact that you want to reserve these for those really nasty multi-drug resistant bugs. Because otherwise, if you have your bacteria getting resistant to these guys, there's really nothing to go to beyond that for the most part. So you really want to save your carbapenems until kind of the last line, or you start to have cultures come back saying that, hey, these are definitely resistant to everything else, right? So you'll see in a lot of hospitals that these are going to be restricted antibiotics or have some kind of approval process or some sort of indications for use that make them okay to use. These will have activity against bacteria that do produce some ESBL, so it's those extended spectrum beta-lactamases. That's, again, why it makes it very good for multi-drug resistant bacteria. But notice that if you have something like a KPC, that's that Klebsiella producing carbapenemase, because it's a carbapenemase, it's going to be having activity against the carbapenems, and so you would not be able to use it in those cases, right? So oftentimes on your culture results, it'll say something like Acinetobacter producing ESBLs and KPCs. And if you see that KPC, chances are your carbapenems are not really going to be all that useful, because they'll just be rendered inert based on that KPC. Does that make sense? Okie dokie. Again, these have good CNS penetration, so they're good for meningitis, really good for nosocomial infections, things like ventilator-acquired pneumonias. These are really good for, and just multi-drug resistant bugs in general. Notice here they're very similar to other beta-lactams. They're going to be these time-dependent killers. They're going to be given several times throughout the day, usually every 6 hours, every 8 hours or so. As far as monitoring goes, it's going to be very, very similar to what you see with other cephalosporins or penicillins. The interesting thing to note here is going to be the seizure risk you can see with imipenem. And so this is something that is you can see in patients who have renal failure. If they start to accumulate this imipenem, they can end up developing seizures. So that's going to be kind of a unique side effect you would see with that. And so in a lot of cases, most hospitals will end up using meropenem as their go-to carbapenem of choice. Okay, so that was it for the beta-lactams. Now we get to move on to some other types of drugs. Next one's going to be vancomycin. Vancomycin is going to be a very common drug seen being used, especially on the inpatient side, for usually broad-spectrum coverage for gram-positives. So vancomycin, while it also works against cell wall synthesis, it's not working through the same mechanism as your penicillins and your cephalosporins. Basically what it's doing is it is directly preventing these cross-linking happening between the cell wall layers, right? So instead of working against the penicillin binding proteins, you're going to be working specifically on this cross-linking activity here. So that's going to be good for bacteria that are producing, say a strain of bacteria starts to produce a different penicillin binding protein that makes your beta-lactams completely ineffective. Vancomycin can still work, right? Because it can still work against this cross-linking here. Again, it goes back to those dealanines that it's trying to inhibit that cross-linking from occurring. So vancomycin only has gram-positive coverage, but of note, it also will cover MRSA. So this is really where you see a lot of use for vancomycin is in empiric therapy when you're concerned about the patient having an MRSA infection. So this is going to be good for, especially if you have patients who are coming in who have say Lyme infections or septicemia and you're worried about MRSA. This is a really good drug to go to with that. Keep in mind that this drug is only administered intravenously, usually. It really doesn't have any oral absorption, so you don't really see like an oral dosage form that's used to treat a systemic infection. On the other hand, though, it does have activity against C. difficile. There's going to be two main drugs we'll talk about that have activity against C. difficile. This is going to be one of them, but you can only administer this one PO. And so you would actually administer it via oral route. It doesn't actually get absorbed systemically, but it can deal with the C. diff that's in the GI tract. Okay. The next drug we'll talk about that has activity against C. diff can be given intravenously and still treat a C. diff infection in the GI tract. This is not the case, though. You don't use IV vancomycin for a C. diff infection, only PO. Okay, so it's an important distinction to make. I've actually seen that in a couple of cases in an ICU where patients on IV vancomycin, they don't really have any evidence of gram-positive infections, but they say it's for C. diff. No, that's not going to work. Got to do the oral dosage form.
It just doesn't cross through the.
It just doesn't really cross. It doesn't get to a concentration enough in the GI tract to have its effect, right?
So the IV doesn't go into the GI.
Yeah, right. It doesn't really get. Yeah, it doesn't get to a concentration high enough to really do anything, right?
The by-mouth one doesn't go out.
Yeah, and when you give it by mouth, it doesn't really get absorbed into through the GI tract anyway. There's actually we had a really interesting case. Interesting from a pharmacy standpoint. We actually had a very young patient who's in the pediatric ICU who had a very significant C. difficile pseudomembranous colitis that was just very, very significant. She was actually status post bone marrow transplant, was having graft versus host issues, and so a very, very sick patient, very immunocompromised. And what we actually did, because she had renal failure as well, is after a period of time we're like, man, I bet her GI tract is just so inflamed and so leaky that she's probably absorbing some of this vancomycin. And so we actually did levels, and sure enough, she was actually absorbing it through this very inflamed and very leaky kind of tissue. So she's actually getting therapeutic blood levels from just oral administration. So it's actually kind of an interesting case, but not something you would see normally. So just keep in mind that oral vancomycin is not absorbed through the GI tract in most cases, and so you're not going to be able to use it for systemic infections.
So what do you do for her?
What we do for her, we actually ended up switching over to a different medication to treat her her issues. And I think at one point we might have even like tried changing the dose, maybe giving it less frequently. It was a couple years ago, so I don't remember exactly what we did. But we ended up stopping it, and then eventually, once the pseudomembranous colitis started to kind of resolve, you started to see the integrity of the GI tract start to come back, and she was absorbing less and less. So it's kind of interesting. This is also going to be good for things like endocarditis, osteomyelitis, things where you're really worried about gram-positive infections. Vancomycin is going to be a good drug to go to, especially if you're concerned about a penallergic patient and you don't want to use anything else. Vancomycin can be used in this case. So vancomycin is a good drug, but it has some toxicities, and this would be one that has a little bit more of a narrow therapeutic index. And so this is one we frequently use therapeutic drug monitoring in order to make sure we get the levels high enough to treat the infection we're trying to get without causing toxicity for the patient. And vancomycin is also going to be a time-dependent killer. So it's really, really important that we get it to a point where vancomycin is staying above the MIC for as long as possible without accumulating to such a level that we're going to start to see toxicity pop up. We'll talk about what that is in a second. So you can look here that this is one of those ones that even for adult patients we'll do weight-based dosing. So say for instance you're going to start, and you can don't memorize the numbers here, but we'll start say 15 to 20 milligrams per kilogram every 8 to 12 hours, depending on the patient, depending on the renal function and whatnot. And keep in mind, though, that some patients, even for very obese ones, you still want to use total body weight for that. You'll see in some cases where you have very large patients and you have to use an adjusted body weight. We won't really talk about that too much, but just be aware that for obese patients, you run some risk of toxicity as you keep increasing the dose as their size gets bigger. But in this case, this is one where you don't want to use any adjusted body weight. You want to use total body weight for the most part. This is also one that you may want to use a loading dose for, especially if they're really sick, in order to get them up to steady state a little bit faster, right? Because remember, loading doses kind of bypass that need to go 4 to 5 half-lives before you really get to a steady state level here. Keep in mind that when you're looking at your MICs, oftentimes this may not get reported, but so it's something you can actually call your micro lab about and figure out what the actual MIC of the bug is. In a lot of cases, if the MIC is greater than 2 milligrams per liter, it's actually so difficult to get the vancomycin levels high enough without causing toxicity that you won't even use the drug. You'll just end up switching over to like an alternative therapy, something like linezolid, which we'll talk about in just a little bit. So keep in mind that even though it's MRSA, and even though it looks like it's susceptible, sometimes that MIC might be so high that it's going to be impossible to keep your vancomycin at a sufficient level, right? Again, as you remember, steady state, again, it's going to take time, and so this is really important when we're doing therapeutic drug monitoring. And you guys remember, how do we do therapeutic drug monitoring? Like, what do we measure?
Peaks and troughs.
Yeah, we're looking at things like peaks and troughs, and actually, with something like vancomycin, we don't really care about the peaks so much. And so what we'll actually end up doing is just measuring the troughs, because we know that we want to make sure the trough is staying above that MIC, right? And so as long as that trough is getting low enough, we don't really care about the peaks, because again, the peak's not really associated with efficacy so much, because we just want to stay above that MIC.
But how do you know you're not toxic?
Because of the fact that you would know you're not toxic based on the fact that the patient's not accumulating higher and higher levels. I have another slide on that, so I'll talk about that in just a second. Just note here, there are some, these are the kind of more recent recommendations as far as dosing vancomycin, just for reference. Notice here that you do need to adjust your frequency based on the patient's renal function. So this is another really important one that we're going to be adjusting based on renal function. So say for instance, if you had a patient who had good kidney function, say over 70 mLs per minute, and again we're using something like the Cockcroft-Gault equation to figure this out, then you can dose it every 8 hours. Patient is able to clear that efficiently. You don't have to worry about accumulation occurring. As we start to get lower and lower renal function, you start to see we can go Q12 hours, Q24 hours, and that allows us time, a longer period of time for the patient to clear it, so that by the time you get that next trough, it will be above the MIC, and then you can redose it. And so what ends up happening if you have patients who have really unstable renal function or really poor function, sometimes what we'll do is just give a single dose, and then we'll do random levels at set periods of time after that to determine at what point they get to that trough level that we're looking for, and then we redose it. So say for a patient who's on, who's at end-stage renal disease, I'm gonna give a dose today. I'll check a trough tomorrow, and the trough's still high. Check a trough the next day, trough's still high, and then maybe on that third day at 72 hours, maybe that's when it gets down to a therapeutic level. Then I can redose it at that point. So it's really, really important to be monitoring your renal function because it's going to definitely tell you how often you're going to be giving this drug. Note you'll be using the same dose because, again, for a lot of these patients, their volume distribution is going to be relatively the same. I can give the same dose and get them up to a certain level, but it might be to give them a longer period of time to metabolize that before I redose them.
When you run your chem profiles and it gives you a GFR, it's like an estimate. Is that what you're using to sort of figure out what the dose is?
Mm-hmm. Yeah, so this would be kind of, usually what happens is you're using population kinetic kind of standards to get what your initial dose is going to be. So this is based off of looking at hundreds of thousands of patients and determining, okay, well, if they have renal function above 70 mLs per minute, you can safely assume that you can give them every 8-hour dosing, right? So you start at that, and then you would do follow-up levels to determine if this patient maybe has something different about their kinetics or kind of an outlier. Maybe that is too much for them, and maybe you do need to get it down to Q12. Right.
But you're running labs on this patient to kind of assess their renal function the whole time they're in the hospital, so they where they're at.
Yeah, and it's something where you're going to be doing initial labs as well. You're going to be doing initial checks on to see what their serum creatinine is, what their creatinine clearance is. But usually when these patients get to a stable point, you don't necessarily need to check their labs every single day, right? So some of our patients, and you'll see very similar things we're doing with something like Aminoglycosides, is that once they are like our CF patients or cystic fibrosis patients, they might be on an aminoglycoside for say 2 or 3 weeks, right? And so what we'll do is we'll actually get them set up on their dose. We've done levels, we know they're at an appropriate dose, and we'll check their renal function maybe every week just to make sure nothing wonky is going on. And as long as they're staying at a relatively stable creatinine clearance, then we know that their drug levels are staying roughly the same.
Question?
Yes.
That's just a refresher.
Sure.
I probably said it before, but how do we determine whether it's concentration-based or time-based? Is it just based on the frequency of dosing?
That's a good way to kind of remind yourself whether or not it's going to be a time versus concentration-dependent killer. So basically, if it's dosed very frequently, so every 4 hours, every 6 hours, every 8 hours, you can kind of assume it's going to be more of a time-dependent killer, right? Because you're dosing it so frequently in order to keep it above the MIC. Because the second you drop below the MIC, what happens?
It's just not going to work.
The bacteria are going to start reproducing, right? And that's what we don't want. So we want to stay above the MIC as long as possible. So the idea with something like vancomycin is once you get at a steady state, at no point do you drop below the MIC, because as you start to dip down, you dose again, and you raise it back up, and then you give another dose and another dose. If you see something given once a day, typically it's going to be more of a concentration-dependent killer, right?
Okay. So once every 24 hours kind of cut off then? Ballpark it?
It depends. Sometimes you'll see concentration minute kills given every 12 hours. Sometimes, depending on the patient's renal function, you may have to give those even less frequently, so say every 36, 48 hours. Just depends.
Okay.
Yep.
And how long do you give the concentration base? Like, why can't you just give it all at once and kill everything you're going to kill?
Okay, so why can't I do that?
Just because of toxicity?
Toxicity, yeah, exactly. So I can give you a dose that's enough to kill every single bacteria in your body off, but it might kill you too, right? Probably not good, right? So that's not really what we're going for. So we are dosing based on being able to achieve good bacterial kill rate without causing so much toxicity, right? And so that's where looking at these therapeutic indexes is so important. So for a lot of them, things like fluoroquinolones, they have such a good safety index that we don't have to do things like therapeutic drug monitoring and check levels. Aminoglycosides, on the other hand, because of their toxicities, much more narrow therapeutic index, we need to do blood levels to make sure you're not going to be becoming toxic by accumulating those drugs over a period of time. Yes?
Are you worried mostly about the toxicity from the drug or also from like endotoxic shock when you're killing the gram-negative bacteria? Is that correct?
Repeat
So
your
with
question.
Is it with gram-negative they have the LPS on the outside, and if you kill them too fast, you can get endotoxic shock because they released all of those into your body?
Yes, in toxic shock, you can end up seeing that endotoxin release. Oftentimes, you're going to be giving actually a drug called Clindamycin. We'll talk about it a little later. Actually, has the ability to bind up that toxin. So even though we're giving Clindamycin not necessarily to kill the bacteria, we're actually giving it to bind up the toxin in order to help prevent some of that kind of shock effect from occurring. Yeah. So anyway, so with vancomycin, the levels that we're generally going to be shooting for, and you'll see here that typically Where's my levels? Here's my levels here. My gold troughs they're going to depend on the indication, right? So depending on where the infection is, it's going to require higher dosing in order to get to sufficient concentrations to really kill off those bacteria. So can anyone think of sites that might be more difficult to get adequate drug levels at? The brain's absolutely a great one, right? So meningitis, you typically have to have very high drug levels in order to penetrate the CNS to get to where it's going. And so again, we're always using blood levels as a surrogate, but that's why we need to use a higher blood level so we know that if it's 15 to 20 micrograms per liter, I know, or micrograms per ml, I know that I have a relatively high concentration in the CNS. I know it's going to be treating that infection. Any other sites you can think of? Bone is another one. Lungs are another big one as well. So lungs can be very difficult to get high levels at in order to treat. So you'll see at different places of dosing guidelines for vancomycin where they say, okay, for these indications, we're going to be shooting for blood levels 15 to 20. In some cases, you can get away with using lower levels for other types of infections. So like bloodstream infections, well, that's pretty easy because it's just in the blood. I'm directly applying the medication to the blood. Those you can shoot for things like lower levels for, so to say like 10 to 15. It's really important, as you remember from when we talked about therapeutic drug monitoring, to not draw your levels too early. So if I were to draw a level, say after the first dose, what is that going to tell me?
Only that it's there.
It's there, but like what have I not achieved yet?
Therapeutic.
Steady state, right? So I need to make sure I'm at steady state before I start to check this. And note that with vancomycin, we're only checking troughs, right? So we want to check the trough before the third or the fourth dose. So that way we're sure that when we're checking that trough that we're at a steady state level. Otherwise, if I check it before, say, the second dose, is it going to be falsely high or low? Should be falsely low. And then I might increase my dose, and then all of a sudden when I get to a new steady state, I recheck it and the patient's super therapeutic, right? It's going to be no good. So you want to make sure you're checking it at steady state levels. And again, you'll sometimes do random levels to check based on if they have really kind of erratic renal function, renal failure. Those are all good times to do random levels to see kind of where they're at, to see whether you're at a level you can redose at. So like I said, with those patients who may have like end-stage renal disease, I may give a dose today, and then I'll check them say 48 hours, and if their level is between 15 and 20, I know that they've metabolized it enough, and say I'll put them on every 48-hour dosing at that point, right? Any questions on that? Make sure you consult your friendly pharmacist if you have a therapeutic drug monitoring program, because they can help you out with all this. Super convenient. They take all the work off you guys. Okay, another thing that you can see with vancomycin in regards to adverse reactions is this thing called red man syndrome. Has anyone heard of this before? Mm-hmm. Right, vancomycin used to be a really, really gross drug. It used to call it Mississippi mud. Very impure. This is before my time practicing, but apparently it was very, very cloudy, kind of turbid mixture. Didn't really look very good. And you saw a lot more of this red man syndrome that occurred here. But a lot of times you'll see the rash that's going to be related to how fast you're actually infusing the drug. So nowadays you have a much more pure variety of vancomycin. It's very clear, it's very nice, but you can still see this red man syndrome that will pop up for patients. Some are going to be more predisposed to it than others, but certainly if they're getting it too quickly, this is where you can see this pop up. I think I'm just a slide somewhere. Just to note on adverse reactions that you can see with vancomycin. So again, the reasons why we're checking levels for these things is because we want to, one, prevent ototoxicity. So you can end up seeing, if you have your levels drawn up too high for vancomycin, you can end up seeing damage to the hair cells and hearing loss. And then you can also potentially see some nephrotoxicity as well. And so that's especially in conjunction with other nephrotoxins. When you start to have multiple of those drugs on at the same time, you end up seeing decreases in their renal function that can occur. Yes? There's probably the possibility you can get it, but it's not one of those ones that you think of as being like really, really irritating to the veins. So the thing with the red man syndrome is that if your patient, usually you see vancomycin as a standard being run over an hour. If your patient does have that developed, you can actually end up running that over 2 hours or even longer in some cases. So depending on the patient, you may need to have pretty long infusions in order to get that in without causing that reaction. In some cases, you can also treat it with things like Benadryl or steroids, but usually just by changing the infusion time, it's usually going to be enough to treat that. Okay. Any questions on vancomycin? Yes.
Is it an allergic reaction?
It's not necessarily an allergic reaction. It's more of I guess you could say it's kind of an allergic reaction. It's just a lot of histamine release and other things like that. They're, they'll be kind of itchy and hot, and, but like I said, you don't always necessarily need to treat it with, allergy medications. You usually just by changing the infusion time. I think it's just having that massive rush in of all the drug causes the histamine release versus if you just kind of do it very slowly, you see less of that release occurring. Okay, moving on, now we can go over to our protein synthesis inhibitors. And as we remember, we said, bacterial cell wall synthesis inhibitors typically were bactericidal. A lot of the drugs we're going to talk about that affect protein synthesis are generally going to be bacteriostatic for the most part. They're not going to necessarily be bactericidal because even though they're inhibiting new protein production, that doesn't really directly kill the bacteria. It may inhibit them from reproducing, but it's not going to kill them directly. It's going to require time for your body's own immune system to come in and kill off the bacteria. So again, the reason why a lot of our antibiotics are specific for bacteria and not us is because they're shooting for different targets. So if you look at things like mammalian ribosomes, we have the 60S and this 40S that come together to make the 80S, whereas on the other hand, bacteria, they have the 50S and the 30S that make the 70S ribosome. So by targeting a different ribosome subsite, they make the drug more selective for the bacteria and not selective for us. Because then otherwise you end up having like chemotherapy drugs, right? So that's why we need the selectivity here. I'm not going to ask you specifically, does this drug work on 50S and this one work on the 30S? I don't really care that you know that because clinically it's never really going to come up unless you have a really mean preceptor. The thing you need to know is that it affects protein synthesis because that's going to be important to know that it's bacteriostatic. Because if you have a patient who is really immunocompromised, these may not be good drugs for them, right? Because they don't really have an immune system to kill off these bacteria. You may need to have other drugs on board that are bactericidal. The first group we'll talk about are going to be our macrolides. And so I'm sure some of you guys have heard of these, things like erythromycin. Lots of dosage forms available for that, including oral, there's IV, there's topical. We have clarithromycin and the azithromycin. Everyone's heard of a Z-Pak, right? Right, everyone's probably had a Z-Pak at some point in their life. Azithromycin is available IV and PO, but most often you'll see it being given orally. And as we said, they're going to be inhibiting bacterial cell growth by inhibiting this 50S ribosome and preventing new proteins from being produced in the bacteria. So macrolides themselves have decent gram-positive and gram-negative coverage. They don't cover things like MRSA, they're not going to cover things like Pseudomonas, but the nice thing that they do cover are going to be some of your atypicals, which this is why these are good for respiratory tract infections when you have atypical bacteria popping up here. So things like your Legionellas, your Mycoplasma, Chlamydia, things like that, these are able to treat those infections. Clinically not really used for anaerobes, so if you're worried about an anaerobic infection, these aren't going to be the drugs to go to. But atypicals is really where the macrolides get a lot of coverage for. Clinically, again, we see them used for lots of different indications, so certainly respiratory tract infections, skin and soft tissue infections. This is an important one here for your patients who maybe have HIV or those that are extremely immunocompromised. This Mycobacterium avium complex, you can either use this as prophylaxis, and so if you're looking at HIV patients, once their CD4 cell counts get down to a certain level, they're more at risk for developing this MAC infection, so you can actually give azithromycin as a preventative, as a prophylactic medication, and then also as a treatment as well. You can see it used with other medications, which we'll talk about when we get to talking about tuberculosis drugs, but ethambutol and rifabutin would be two of those as well. Again, you can use these for chlamydia, and then also you'll sometimes see macrolides used for treatment of H. pylori, and you see those infections causing what? Yeah, gastric ulcers, right? So those H. pylori infections, you utilize a macrolide in combination with things like amoxicillin and lansoprazole in order to eradicate that infection. Lansoprazole itself is not a antibiotic; it's actually a proton pump inhibitor. But we'll talk about that in the GI section. I think you had a question in the back.
Oh yeah.
Yes.
How do you do prophylaxis with like a chronic issue? So HIV prophylaxis, would they always be on it? Or?
Yeah, that's a good question. So they have guidelines, and it's based on their CD4 cell count. So once their cell count gets down to a certain level, they know they're more at risk for different things. So you'll see things like prophylaxis for cytomegalovirus or MAC or pneumocystis carinii. PCP prophylaxis, basically. And so once they get down to a certain CD4 cell count, they're at risk, then you put them on the prophylaxis. Now, say they change their drug regimen around, all of a sudden their CD4 cell count rises again, you can take them off the prophylaxis, right? So it all depends on that. And you have guidelines that help you out with that, those kind of questions. Yes?
It was actually just a really short question, and active drug, then does that make them more susceptible to like getting resistance to these bacteria?
You run the possibility, but what we see clinically is that things like Mycobacterium don't generally develop a ton of resistance like you would see with like some of your gram-negative bugs and things like that. So you don't necessarily worry about the resistance in cases like that. Clinically, it doesn't really come up. That'd be an issue. Something else you might see some of these drugs being used for, the macrolides, is that some of them have activity on the motilin receptors in the GI tract, and so they can actually be prokinetic agents. So sometimes you'll see erythromycin being used chronically for patients as a prokinetic agent. So if they have gastroparesis, especially like your diabetics, sometimes with a lot of our GI kids over at Nemours, we'll see them being on erythromycin as a prokinetic agent. Azithromycin has some activity as well, but usually you see erythromycin being done for that.
You know what a prokinetic agent is?
Prokinetic agent means it's going to be stimulating the GI tract to start pushing things through, right? So if you have issues where they're having, say, slowed GI transit times, they're not processing food appropriately, having lots of reflux, sometimes you can give them drugs that will affect these motilin receptors in order to kind of help push things through and get things moving appropriately. Other thing you might see azithromycin, I can't talk, being used for is it does have some anti-inflammatory properties itself. So sometimes you'll see kids with cystic fibrosis who have this kind of chronic lung inflammation that's occurring. They will actually be on azithromycin chronically in order to help decrease a lot of that inflammation from occurring, because otherwise they get a lot of pulmonary fibrosis long term, and so this can kind of help prevent some of that. Again, they're not using it really as an antibiotic specifically, but they're using it more for the anti-inflammatory properties you can see with that. So as you might imagine, if they are prokinetic agents, meaning they're pushing things through the GI tract, you might imagine that nausea, diarrhea, things like that are going to be common side effects, especially abdominal pain. So certainly you can see that, especially with the erythromycin. You can still have allergic reactions. Sometimes you'll have some cholestatic hepatitis. It's pretty rare, and it's seen with some less often used forms of erythromycin, this estelate. And then in some cases, you worry about having transient hearing losses. And so this can happen if you have large IV doses or if they are receiving it orally and they have renal insufficiency and they're accumulating the drug. So this can have some ototoxicity there as well. Another point to make mention of here is that these drugs can cause QT prolongation. Does anyone know what QT prolongation puts you at risk for? It's on the slide. Torsades, right? You guys know what torsades de pointes is? Okay, it's a fancy French word. You learned about it from Professor Quinones probably. It is basically, and I'll talk a bit more about it in a second, where you have this delayed repolarization of the ventricles that can lead you to be at risk for developing this very erratic looking ventricular fibrillation called torsades. And so many drugs can cause QT prolongation. I have a slide on that in a second. But when you see this pop up, it's important to note that, because especially some of your patients who might be on multiple medications that all can prolong their QT interval, and some patients just have genetic, congenital prolonged QT. This can be a big issue for them. It can be, cause for sudden death in an otherwise, relatively healthy patient, right? So something to keep in mind. You're going to see this more be a risk if patients have underlying electrolyte disturbances, so especially if they're hypocalcemic, this can be a big problem, or if they're on other antiarrhythmics, they can also be at risk for developing this. Other big things you want to focus on for macrolides is CYP interactions. You guys remember what the most common CYP is for metabolizing drugs? It's breaking my heart. 3A4. 3A4 is over 50% of all the drugs get metabolized by CYP3A4. So that's a really, really important one. And these are super important because the macrolides inhibit CYP3A4. And so these are a good thing for testing purposes, I'm just saying. So many of these are going to be CYP inhibitors, specifically of 3A4. And you can see here that erythromycin is going to be the most potent. You have chlorothromycin, and then azithromycin is relatively low compared to those. And so if you have a drug on board that is being metabolized by CYP3A4, and then I add on a macrolide, what's it going to do to those drug levels? Go up or down? Because I'm inhibiting CYP, so it should cause drug levels to go up, right? Because I'm inhibiting the enzyme, so not as much of the drug is being metabolized. So if I have, say, a patient who is on carbamazepine for seizures, all of a sudden I give them a CYP inhibitor like erythromycin, all of a sudden their carbamazepine levels start to shoot up. They're at risk for having significant CNS depression, ataxia. They can be a fall risk, can be issues. Things like antiarrhythmics like digoxin can be really, really dangerous if you drive up those levels. Can lead to arrhythmias. Bless you. So always check your drug interactions prior to prescribing one of these to make sure you're not going to have any big issues there. So I didn't put an actual rhythm of what torsades looks like, but if you just do a Google search, everyone has their computer, you can see what it looks like. It's kind of interesting. You never want to see that on an actual patient because that probably means they're not alive at the moment. But anyway, so essentially what's happening here is that you will have drugs that are affecting this HERG channel, and this is responsible for potassium efflux, right? So when you're looking at the cardiac conduction cycle, that potassium efflux is really important to helping the ventricles repolarize. And so when you block potassium from coming out, you're going to keep the inside of that cell more positive for longer. And so you see that period of time is going to prolong out. So you have QT prolongation occurring. And so when you have that, you run the risk of having this reentrant rhythm that develops leading to torsades. And so it's a really kind of like interesting squiggly line of a rhythm. And it's something that's so kind of obvious that even a pharmacist can see it. So if I can see it on a monitor, you know it's bad. If it's a straight line, that's also bad. But this one actually has a very interesting look to it. So again, make note of things that prolong QT interval because those will come back up, and those are important drug interactions to know of. Moving on, then we have our tetracyclines. So this will include tetracycline itself, doxycycline, and also minocycline. So these again are going to be blocking protein production within the cell by working against the 30S ribosome. Again, these are going to be bacteriostatic, and in general, the tetracyclines are pretty broad spectrum for the most part. So these are older medications that are used for lots of different indications. We see they have decent activity against gram-positives, gram-negatives, and some anaerobic coverage, which is nice, but it doesn't really have any coverage against things like Pseudomonas or C. diff. Make note of that. It does have good atypical coverage as well, and it's also good for certain animal-borne organisms. So if you ever look at like biological terror attacks and things like that, if you look at the CDC guidelines for the antibiotics used for a lot of those type of attacks, doxycycline is like the #1 on the list for most of them. So if there's ever like a plague outbreak, doxycycline is probably the drug you're going to take for that. Note that tetracycline and minocycline is available PO. You see a lot of those being used for things, certain derm conditions like acne. You can see tetracycline is being used. And then doxycycline has the ability to be given IV as well, which is handy in some cases. Again, you can see it used for acnes, atypical pneumonias, with things like mycoplasma cause issues, animal-borne other diseases, things like Rocky Mountain spotted fever, Lyme disease, and then certain STDs can be treated with this as well. Big things to note, drug interaction-wise, is one, this is going to chelate with cation. So this is an important food-drug interaction. So if I were to take, say, doxycycline with milk, what's going to happen? It's going to bind to the calcium, and then does it get absorbed through the GI tract? No, right? So my treatment failure, a patient who's taking doxycycline, they're not getting any better. Could be that the treating a resistant bug, could be many issues, but it could be a dietary interaction you're seeing there. So ask them if they're taking it with milk, ask them if they're taking it with iron, because both of those can chelate the tetracyclines and lead to decreased absorption. Other things you really want to make note of is that you can have some photosensitivity. So again, make sure they're wearing things like sunscreen if they're going out or wearing good sun protection. But the big thing to note here is the discoloration of the teeth. And so this is a big contraindication for, one, pregnant females, because it can affect the fetus. And then the other one's going to be really avoided in kids less than 8 years old. Because again, they're still going to have their adult teeth coming in, and you don't want to stain those teeth, right? It can also have some risk of depression of the skeletal bone growth, so again, don't use it in kids less than 8 for the most part. And again, these should be renally dose adjusted as well, so keep that in mind. Kind of similar to the tetracyclines, at least in structure, is going to be this glycylcycline group, which includes one drug. It's going to be Tygacycline or Tygacil. This used to be one of my favorite antibiotics because it is a nice orange color. I'll show you a picture of that in a second. But Tigecycline is, again, going to be a drug that inhibits protein synthesis at the 30S ribosome. This one has really, really good coverage against a lot of different things. Gram positives, gram negatives, aerobes. This is able to treat Pseudomonas. Also has some MRSA coverage. So these are good for lots of different bugs. The problem is it's bacteriostatic, and so if you have a really, really sick patient, they may not be able to clear that infection on their own if they have a weakened immune system. So they've actually seen in some cases where you're using Tigecycline, it's actually led to increased mortality in those patients treated with this. So it's not really seen used all that often, but sometimes if you have bacteria that are resistant to everything else, sometimes they'll remain sensitive to Tigecycline. Again, there's a nice picture of it. I just like the orange color. You don't see things that have really good colors to them very often, but this is another. Yeah, it's kind of cool looking. Plus, all their marketing had like a lion walking or a tiger walking with a doctor down the hallways, which I thought was kind of cool. Like, I want that doctor. Anywho, as far as adverse reactions, nothing really special to note here. Notice here this drug does include a loading dose, so it's made to get to steady state a little bit earlier, and then given every 12 hours after that at a lower dose. All right, moving on. Another big group that's important, especially on the inpatient side, is going to be the aminoglycosides. This is going to include amikacin, gentamicin, and then tobramycin. So these have very similar coverage to what we saw with our monobactams, that as Trianam, is that this is really only going to be good for gram-negative coverage, right? We'll be able to treat things like Pseudomonas, but any gram-positive is not going to be having good activity against. So you'll oftentimes see this used in conjunction with another agent. So if you're double covering for things like Pseudomonas, you'll see this in conjunction with something like a cell wall synthesis inhibitor. So you'll see used with something like a piperacillin tazobactam or cefepime in order to help get some synergy there and kill off some of those gram-negative bugs. But this is really good for gram-negatives. Even resistant ones tend to have some susceptibility to this for a period of time. Sometimes you'll see it used for enterococcal coverage, but it's only being used in synergy with something like a penicillin. So that's the only time you see it used specifically for a gram-positive infection. Now this one's interesting because even though it works on bacterial protein synthesis, it is actually bactericidal. I don't really have a good reason for that, but it's bactericidal. And so it's also going to be a concentration-dependent killer. Traditionally, it used to be given every 8 hours, and in some cases it still is, but nowadays we realize that it has that post-antibiotic effect and it has really good concentration-dependent killing. So in a lot of cases, you're only going to give it once a day. And so this would be one where if you're giving it once a day, I can end up checking trough levels to make sure you're not accumulating. So this is going to be another one we're going to do therapeutic drug monitoring on. As far as the considerations, the toxicity that we're worried about, the main things are going to be renal toxicity. So especially if you have a patient who's already septic and they're already having poor renal perfusion, this can just kind of add insult to injury and lead to further depression in renal function, and then also ototoxicity, right? So similar to what we saw with vancomycin, have damage to those hair cells and cause potentially permanent loss of hearing. So this is why the therapeutic index is narrow enough. We want to make sure we're doing good therapeutic drug monitoring to make sure we're keeping our levels appropriate. Yes?
On that previous slide, what is enterococcal synergy?
So that is where you are, so enterococcal synergy is where you're using two drugs at the same time in order to have better activity than either one of them by themselves, right? So for instance, when you're having like endocarditis prophylaxis or treatment, sometimes you'll see like penicillin being used along with an aminoglycoside. Essentially, kind of what's happening is that the cell wall synthesis inhibitor, like a penicillin, is kind of loosening things up so the aminoglycoside is able to kind of get into the cell more easily and have its activity. So that synergy is just you get some that's greater than either of its single parts, right? Yes.
Can a bacteriostatic drug be considered a concentration-dependent killer?
It's possible, yeah. So you don't just because something is bacteriostatic doesn't mean that it's necessarily time-dependent or concentration-dependent. Those are kind of two separate things there.
So the fact that it says killer, it's not actually killing them.
But so the aminoglycoside is an exception. That even though it's inhibiting protein synthesis, it's still bactericidal. Yep.
I'm just saying for like a bacteriostatic.
So, sorry.
That's okay. I think I got what you said.
You got it?
Yeah.
Okay. Everyone else got it? Hopefully. I don't know. anyway, so you see the dosing is pretty similar with gentamicin and topramycin, which is kind of nice because you just give one dose. Amikacin, though, you always give a bigger dose of that one, so just something to note there. And then when you're checking your levels, again, you're checking for your troughs here. So when we're giving it one time a day, you'll check your troughs because essentially you're giving such a big dose that you know, because it's a concentration-dependent killer and that based on this weight-based dosing, I know that whatever level I'm going to have in that patient is going to be sufficient to kill off this bacteria. I just want to make sure they're not accumulating the drug to lead to that ototoxicity and the nephrotoxicity, right? In some cases, if I were to dose this drug every 8 hours, that would be a case where I'm actually going to do peaks and troughs in order to make sure I'm getting high enough to actually kill off the bacteria. But if I'm just doing one big mega dose a day, I already know that level is going to be high enough to do what I need it to do. Does that make sense? All right. Again, this is going to be one of those things where you do not want to draw a trough too early, because if you do, you may not have the full picture. So you want to make sure you're doing it before the third or fourth dose to make sure you're at steady state. And then typically you're going to draw your peaks 30 minutes after the end of the infusion, and then you'll get your troughs roughly 15-30 minutes before. And then based on those levels, you can start to do some pharmacokinetic calculations to determine what the half-life of the drug is for that patient, what the volume of distribution is. I'm not mean and going to make you guys do all that, but just call your pharmacist. They can do it for you and figure it out for you. All right, moving on, we have our we have linezolid. I won't make you pronounce that name, it's really hard to say. But anywho, you have linezolid or Zyvox. This is going to be a really good alternative to vancomycin. It's very similar coverage. It's going to be used primarily for gram-positives alone. No real gram-negative coverage here. The nice thing here is that if you have something that's resistant to vancomycin, so you have like a vancomycin-resistant Staph aureus, or you have a vancomycin-resistant Enterococcus, you can utilize linezolid, because it will generally be susceptible to linezolid. So very good agent for that. It's very, very expensive, so you typically do not want to jump to this drug unless there's some really big contraindication they can't receive the vancomycin. So you'll typically see this used as like a second or third line agent in those cases. One of the interesting toxicities to note with this one is that it has some activity as a monoamine oxidase inhibitor. So we'll talk more about this when we get to the psych section, but essentially all the catecholamines in the CNS, things like epinephrine, norepinephrine, serotonin, they get metabolized by a couple of different enzymes, and one of those is monoamine oxidase. And so an early type of antidepressant was monoamine oxidase inhibitors. So by inhibiting those enzymes, you had increased levels of serotonin, and that was thought to eventually lead to relief of depression, right? They're horribly toxic, though, so we don't really use them very much anymore. This drug, on the other hand, though, does have some activity against that monoamine oxidase. So what you end up seeing is these drug interactions where patients who are on SSRIs, which are selective serotonin reuptake inhibitors, things like Prozac, like fluoxetine, or Lexapro, which is escitalopram, they can have an interaction where they basically will be working together to increase those serotonin levels and can lead to serotonin toxicity, right? Serotonin syndrome in more severe cases. You also can have interactions where if you're consuming food that's high in tyramine, you can also have that being converted over to things like norepinephrine, epinephrine, and not being able to really metabolize it, which can lead to hypertension, tachycardia, chest pain, all things like that. Does anyone know which foods are high in tyramine?
Red wine and beans.
Red wine, like fava beans are really big in it. Anything else? Like aged meat and cheeses are noted to be high in tyramine. Red wine. I should mention that. Right, so all like the really good food, like no fancy parties while you're on linezolid, because most of that stuff's gonna be high in tyramine. So avoid that. There's one other drug that we have that is really good for vancomycin-resistant Enterococcus, and this is going to be one called daptomycin. And so daptomycin, otherwise known as Cubicin, again has very similar coverage to your vancomycins and your linezolids, because it's really only going to be good for resistant gram-positive bacteria. Daptomycin is kind of interesting, though, in that linezolid works against the 50S ribosome, so it's a different mechanism than vancomycin, which is why if you have a bug that's resistant to vancomycin, you can use something like linezolid because it's a totally different mechanism. Similarly, daptomycin has a totally different mechanism as well, and essentially what it does is it can go in and causes the bacterial depolarization, and so by doing this depolarization of the whole cell, it inhibits DNA, RNA, protein synthesis, so it's actually able to be bactericidal and kill off these bacteria. So it's very good at what it does. There's just some issues with it as far as toxicity goes. It's also pretty costly, and so one of the big things you're going to be seeing is some degree of muscle breakdown. So muscle pain is a very common side effect with daptomycin, and you can also run into issues of increased creatine phosphokinase, or a sign of muscle breakdown occurring, so you can sometimes see that as well. So, if your patients are complaining of new onset muscle pain, it could be a sign that they're having toxicity from this daptomycin. One more thing. So the other thing to note here is that this cannot be used in pneumonias. And the reason for that is because the surfactant in the lung is actually able to disrupt the daptomycin and actually it makes it inert. So never ever use daptomycin for a pneumonia. You got to find some other drug. But this is why it's really better for things like bloodstream infections, because again, it's able to get to its site where it's needed to work just fine. See someone with a question?
Yeah, I made a note to ask you a question about this. In micro, we learned that the mechanism of action was two different things. It said to disrupt the cell wall and to inhibit the plasma membrane. To disrupt the plasma membrane. So, what is it exactly? Because she said she consulted you about it too.
She said you guys would be asking me about it, so that was her consult. She's like, they're going to come ask you about this. My recollection, there are some that are actually going to actually disrupt the cell membrane by actually like intercalating into the actual cell wall, and that'll be things like your polymyxins that we'll see. From daptomycin standpoint, it's basically just causing this depolarization. So however it's doing that, it might cause a puncture in the cell wall, but essentially it's causing this depolarization that will lead to that inhibition of the DNA and RNA and protein synthesis. So that's my understanding of it. That's what Lexicomp says, which is my kind of go-to drug reference.
So this is the mechanism of action.
As I know it, that's the mechanism of action. There's lots of drugs though that will have things where like, we don't really know the mechanism, it just works. But as far as I know, this is this one. When we talk about polymyxins, those are going to be ones that are going to directly kind of pierce the cell wall in order to kind of lyse it open. If you guys see something different, let me know though, because I'm certainly fallible. Let me know. Any other questions? Okay. I will let you guys go for a break. We'll come back and we'll continue this and hopefully get to our ENT section. Next up, we will talk about another very important class of antibiotics that you should not overuse. Would be our fluoroquinolones. So this is going to include, most commonly, you'll see levofloxacin, ciprofloxacin, and moxifloxacin. Those are probably the most common ones you'll see in practice. There are other ones out there, but certainly these three are probably the most common. So as we mentioned back in the ophthalmology lecture, we mentioned there's certainly some fluoroquinolones you can use for those indications. We have the mechanism here where it's basically working on two different enzymes. One's going to be this topoisomerase 4, and the other one's going to be on this DNA gyrase. And just know that these are really important for kind of relaxing the superhelical structure of DNA so that it can be translated and eventually produce new proteins and whatnot. Note here that by inhibiting this activity, you're going to lead to more strain breaks and more kind of degradation of the DNA, which will eventually lead to apoptosis and cell death, right? So that's kind of the idea. As you damage the DNA enough, eventually it's going to just decide to off itself. I mean, essentially it's cell suicide, right? So fluoroquinolones, some key points to know as far as activity goes. They have very broad spectrum antibiotics. They are the drug of choice for community-acquired pneumonia in a lot of cases. Note that you do not want to use ciprofloxacin for this. You don't really get good enough coverage with cipro in the lungs, and so you generally are going to avoid that. You can see it used for things like sinusitis, otitis, hospital-acquired pneumonias. Sometimes you'll end up seeing bigger doses being used for that. So certainly like some nosocomial pneumonias. UTIs can be another place where you can see these being used. Note here, though, you do not want to use moxifloxacin. Moxifloxacin is unique with the fluoroquinolones in that it's not excreted through the kidneys. Moxi is actually metabolized within the liver, and so in order to get to its site of action, it's going to be metabolized before it ever gets to the kidneys, so it's not going to be good activity there. Skin, generally don't want to use ciprofloxacin. Again, it's just not really good coverage. Sometimes you can use it for osteomyelitis, especially if you're worried about like gram-negatives being a causative organism. This would be a good option here. As far as interactions go, this is important to note for that food-drug interaction, similar to the other class of drugs we talked about that has this chelation effect. You guys remember what class that was? Tetracyclines, right? So if you were to have things like iron, antacids, especially calcium-containing ones, dairy products, those can all bind up your fluoroquinolones and lead to less absorption and treatment failure. This is another group that's also going to cause QT prolongation. So again, you want to be worried about torsades if you have a patient who's specifically at risk. So again, hypocalcemia, hypokalemia, if they have congenital prolonged QT, if they have other drugs prolonged QT on board, those would all be the patients you'd want to worry about. You can also see some CNS effects within the elderly. So sometimes you'll have mental status changes in your elderly patients, which could be explained. It's kind of one of those things where it's like, for your elderly patient who's having new onset mental status changes, is it the UTI that's causing that, or is it the drug I just gave them? Sometimes it's kind of a chicken or egg type situation.
Is that why they don't like to give Septra to old people every year?
Generally, yeah. Yep.
I asked someone that yesterday, like one of the professors, and she told me to ask.
Yeah, so they're more at risk for having these CNS changes. You don't really see it in younger patients necessarily. Other things to note here as well is that you can see tendinitis, and you worry about Achilles tendon rupture. So this is why you frequently try to avoid these in younger patients, but sometimes you'll still see them being used depending on the indication and what the bugs are susceptible to. Huge amount of overuse with these drugs because, again, they're so broad spectrum. They treat a lot of things. So if you have a patient who's coming in for sinusitis and all these upper respiratory tract infections, you can just throw Levaquin at them and everything will be fixed, right? Especially all the viruses that you're not actually treating. So overuse is really big, and so you see a lot of resistance developing to these to the point where in a lot of cases they're useless for your indication when you get those cultures back. Sometimes you'll see this used in combination with other medications for double coverage of things like Pseudomonas. So that's going to be good for your patients who are coming in from that you're worried about a healthcare acquired infection. If you're double covering for Pseudomonas, you can see something like a piperacillin Bactrim plus a Levaquin because they'll have good double coverage and hopefully be able to treat that Pseudomonas. So again, these will have Pseudomonal coverage, so those are good for that as well. There's a couple of different generations of fluoroquinolones. It's not so important to memorize the generations for these guys as you would for something like the cephalosporins, but just to know there are some differences here. Cipro has good gram-negative and good atypical coverage, and it can have plus or minus on the Pseudomonas, so it's not always great for being used for that. That's why you kind of avoid using it for, especially if you're worried about Pseudomonas in the lungs. It's not going to be awesome for treating that. Again, all of these fluoroquinolones are going to be renally dose adjusted, so it's important to look for renal dysfunction as well. Moving on to your third generation, you have levofloxacin or Levaquin. This is probably one of the, Cipro and Levaquin are probably one of the very common ones that are prescribed. This has additional gram-positive activity and very good Pseudomonas coverage for the most part, unless it's resistant. So you'll see this being used a lot for community-acquired pneumonias, strep pneumo, atypical coverage. These are really good for that as well. And again, look out for renal dosing. Moxifloxacin still falls into that third generation category, but just remember, because it's being metabolized in the liver, it's not going to be good for kidney issues because it will not get to sufficient concentrations within the kidneys to really cause the action that you're looking for. Again, we mentioned some of the side effects, so it's going to complex with cations, so that iron, calcium, chelation you can see there can prevent absorption. You can see some photosensitivity. As far as CYP interactions go, this affects 1A2, which is not something that comes up very often clinically, so you're not really too worried about CYP interactions with fluoroquinolones like you would be for something like your macrolides. We already mentioned QT prolongation and that tendon rupture, so caution if your patients are less than 18 years of age. Just let them know that it'd be something to watch out for. If they're starting to complain of new pain, anything like that, you want to make sure that they call in and see if you need to switch it over to something else, right? So a very big thing because you don't want their tendons to rupture on you, and you kind of be on the hook for that. All right. Moving on, then we have our Clindamycin, otherwise known as Cleocin. This drug is interesting in its coverage because it is really good for gram-positive aerobes and gram-positive anaerobes, but no gram-negative coverage. So this is going to be used a lot for things like skin and soft tissue infections, and also if you're worried about aerobic infections. And kind of what a lot of people will do is they'll say that they'll kind of use the diaphragm as a line to say which anaerobic coverage you're going to be looking for. It's to kind of say if you're above the diaphragm, you're going to go with clindamycin. If you're below the diaphragm, you're going to go with metronidazole. That doesn't always hold out in clinical practice, but certainly clindamycin, if you're worried about like an aspiration pneumonia with an atypical bug, that can be utilized for that. But again, no gram-negative coverage here. So you'll oftentimes see it used in combination with another drug if you're worried about gram-negatives. You certainly can see, oh yes?
Does this drug fit? Is it a
Oh, sorry. It's actually kind of it's called a lincosamide. So it's going to be in its kind of own category. So it's not a fluoroquinolone. They kind of moved on from that. Fluoroquinolones are old news now. I'm just kidding. So the other thing to note, and someone mentioned this with toxic shock syndrome, which is also hard to say, that you'll oftentimes see clindamycin being utilized, but it's not necessary to treat the bacteria that you're worried about. What it actually can do is bind up some of the toxins that are being released by the bacteria. So you can actually use it to bind up those toxins and prevent kind of the full shock picture from developing for your patient. So if you ever see that being utilized, that's what it's being used for. Clindamycin, you can see certainly some blood dyscrasias here, see some rash associated with it, but the big thing to note with clindamycin is that this is probably the most likely one to cause C. difficile infections and pseudomembranous colitis. So diarrhea is going to be a huge issue with this one. Just let your patients know to be wary of that. Certainly can consider things like probiotics on, if they start to have really, really significant diarrhea in order to maybe prevent C. diff from popping up. May not always work, but it may help. Okay, moving on to another class of antibiotics. This is going to be sulfamethoxazole and trimethoprim. We've mentioned these classes of drugs before. We talked about the ophthalmic section, but essentially these two drugs are working in tandem to prevent folic acid processing within the bacterial cell. So they're working through two different mechanisms, but they're working on the same process. So if you look here, sulfamethoxazole, trimethoprim, Bactrim is one of the brand names, so used very, very frequently for some skin and soft tissue infections, certainly for UTIs. One other place we'll see it used very frequently, especially if you're working like on a hem-onc unit, is if you're worried about prophylaxis for things like PCP pneumonia. Same thing for HIV patients who are a little bit further along their disease process. The way this is going to work is that you have sulfamethoxazole, which is going to be your sulfonamide here, which is going to be inhibiting the conversion of this para-aminobenzoic acid, or PABA, from being converted over to dihydrofolic acid. Okay. And then you have trimethoprim, which inhibits the conversion of dihydrofolic acid over to tetrahydrofolate. So two-step process, each one's working on a different step to inhibit the folic acid from being finally used. And so if you prevent that from occurring, you're going to prevent DNA synthesis, you prevent, basically end up causing cell death to occur eventually. So good agents for those that are susceptible to it.
So this is a bactericidal?
Yes, because it's going to be eventually affecting DNA synthesis, so yeah. Again, this is going to be good for gram-positive coverage. It's going to end up covering some strains of MRSA. In a lot of cases, clindamycin also can end up having some MRSA coverage, but you really need to look at what your local resistance patterns are like. We talked about those antibiograms being important for looking at local resistance patterns. In some cases, you'll see places where MRSA coverage of clindamycin is really poor, and other places you'll see where Bactrim is not really going to be a good treatment for MRSA. So be aware of that. Make sure you know which one you're going to be prescribing if you're concerned about things like community-acquired MRSA. This will also have some decent gram-negative coverage as well. This actually has some interesting coverage for certain patient populations. So I mentioned, cystic fibrosis patients have really kind of thick, gunky lungs that just harbor all kinds of weird bugs. And when they get further along in their disease process, they start growing things like Stenotrophomonas multifida. They grow things like Burkholderia cepacia, things that we're exposed to all the time, but because we have a competent immune system, we don't really get infected with. These patients, though, are considered to be immunocompromised, and they develop these infections. And so Bactrim is going to have a good coverage against some of those more kind of oddball bugs that pop up in those patients. Again, we talked about treatment and prophylaxis of PCP pneumonia. It's that pneumocystis carinii pneumonia. UTIs, bacterial prostatitis can be good indications for this one. Respiratory tract infections, I usually don't see it used too often for respiratory tract infections. And then in some cases you can utilize it for things like enteritis due to Shigella, traveler's diarrhea can be useful against that. As far as adverse effects go, certainly hypersensitivity and rash can be seen with this one. You have some photosensitivity. Certainly this is a big one. You worry about things like Stevens-Johnson syndrome and toxic epidermal necrolysis. And then obviously what allergy are you worried about? Yeah, sulfonamide allergies for the sulfamethoxazole. So you want to make sure you're checking your allergies beforehand. There are some drug interactions that can occur here, so you can certainly see big interactions with warfarin. That's going to be a big one you want to watch out for. especially for your older patients who are on anticoagulation with warfarin, because it does inhibit CYP2C9, which is an important enzyme that's responsible for metabolizing warfarin itself. Also see some other issues where you end up having some increases in levels of other drugs, things like phenytoin, which is an antiepileptic, Tygacil, so you can see some other drug interactions there. Again, check your interactions before prescribing. I had a really scary moment with when I was in rotations and I was at an ambulatory site, and I was actually running an anti-coag clinic, but they also had like a little retail pharmacy that I worked at, and there was it's like a family healthcare clinic, and so there's an NP that worked there, and she came up to me, she's like, hey, you remember filling this Bactrim for this guy? And I was like, yeah, I remember filling that, I remember talking to the guy. She's like, yeah, did you know he was like on warfarin? And I was like, no. And she's like, yeah, I checked his INR, you know what it was? And I was like, oh, no. Does anyone know what like a normal INR is?
2 to 1.
1 should be a normal INR. 2 to 3 is what you want to do if you're like anticoagulant. She's like, it was 9. And I was like, and I probably had to go change my pants. And then she was like, no, I'm just kidding. His INR is fine. He's actually subtherapeutic beforehand. So, but be aware of those interactions, because you never want to have those type of feeling of like, oh crap, I missed something big. Because again, if that patient went and did have an INR of 9 and went and hit his head and bled out, that could be a really big deal, right? So check your interactions. Another big one, that's why you make your mistakes as a student, because that way you have less culpability and you blame it on your preceptor, right? Yeah, don't kill anyone anyway. That's just general good advice. Moving on, then you have your metronidazole, otherwise known as Flagyl. This is going to be another one that has good activity for anaerobes. Metronidazole is also interesting because it has good activity against certain parasites. So this is where you'll see it being used most often. This one is going to be interacting with the bacterial DNA itself, and so it actually causes strand breakage and interacts with the helical structure. So a little bit different mechanism, but again, it affecting the DNA synthesis is going to eventually lead to cell death there. So like I said, anaerobes and parasites are the big thing that metronidazole is going to be used for. This is the other drug of choice. Typically, this is your first-line drug of choice for C. difficile infections. So we mentioned the other one being, I don't remember, vancomycin. And so this is the one you can either give IV or PO. Obviously, you want to try to do PO if possible, but then sometimes really severe infections will give IV. But remember the vancomycin, you can only give PO in order to treat C. diff infections. But this one you also see used for a lot of sexually transmitted infections and also intra-abdominal combinations. So you'll see like this one being used for anaerobic coverage, and you'll see it in conjunction with like a cephalosporin. So say for instance, I had one of the things we did over at Nemours for our surgical patients who are being transferred in for complicated appendicitis. If they wanted to cover for all these intra-abdominal bugs that could be getting released from the appendix, they would actually do ceftriaxone, which you remember has good gram-negative and gram-positive coverage, on top of metronidazole as a surgical prophylaxis, and that way you got your anaerobes covered in there as well, right? You didn't cover for Enterococcus, but in most cases this is just for prophylaxis, not for actual infection in that case. All right, so sometimes you'll see it used in combination. You also saw previously we talked about the not ceftarolines, the other one. I think cetolazone and the Tazobactam. That one was approved in combination with metronidazole for intra-abdominal infection. So again, you'll see it used in combination usually. The big side effect to note here with metronidazole, the big kind of claim to fame, is this disulfiram reaction. Does anyone know what that is?
Makes you throw up with ETOH.
Okay, it makes you throw up with ETOH, which is ethanol. What's happening there? Does anyone know? Kind of interesting. So disulfiram, the brand name for that drug, it's an older drug, it's called Antabuse. It was designed to prevent people from abusing, or deter them from abusing alcohol. And essentially what happens is that metabolism of alcohol occurs in a two-step process. You have alcohol dehydrogenase, which will convert the ethanol over to this acetaldehyde. And then eventually you have acetaldehyde dehydrogenase, which is converted over to, eventually go over CO2 and water. CO2 and water. So the disulfiram actually inhibits that acetaldehyde dehydrogenase, and that acetaldehyde buildup is what leads to a lot of flushing, leads to a lot of nausea, vomiting, that leads to that really bad feeling when you end up drinking in combination with something like a Flagyl, right? So we can probably end up talking more about that if we run into it again. But just be aware that warn your patients, don't drink while they're on metronidazole, because they're going to feel pretty icky afterwards, right?
I have a question.
Yes.
For the dosing, it says 8 to 6 hours, so it's supposed to be 16, not 16.
No, it could have been 6 to 8, but I was probably just dyslexic for that moment. Or I was thinking less frequently to more frequently. That's probably what I was thinking of. Okay, then moving on, we have another group of medication. You normally see these polymyxins being used topically because these are super toxic drugs. These are the ones I was mentioning that work by basically kind of piercing through the cell membrane to lyse them open. And so they're not necessarily super specific for just bacterial cells. They can do it for people cells too, which is where you see a lot of these, the toxicity comes from. These are really good gram-negative killers. They are similar in activity to your aminoglycosides, but essentially we don't use these systemically because the toxicity is so bad. So what you're going to end up seeing is a lot of ototoxicity, a lot of nephrotoxicity, and a lot of CNS toxicity as well. So the only case where I've ever really seen polymyxin being used was cases where you'd have these really super sick ICU patients who had these ventilator-acquired pneumonias. They have exhausted every single carbapenem, aminoglycoside, everything is resistant except for polymyxin. Right, and so you're like, well, this patient's already sick as snot anyway. Let's go ahead and just kill his kidneys while we're at it, and you give them that to hopefully clear that infection. Right, usually those are patients that don't do well in the end anyway, but you gotta try what you can. So like I said, the reason why there's not a ton of resistance to these is because they're so toxic. It hasn't really been used a lot for the last 50 years. But as we have these emergence of these really nasty gram-negative infections, this is where you've seen more use of it. So it's really kind of a last-ditch effort in a lot of cases. So again, look at the black box warning. You see there, nephrotoxicity, neurotoxicity. Another interesting one is it actually can prolong the activity of neuromuscular blockers. So those are paralytics. So if you have a patient who's on the ventilator, oftentimes they're on paralytics in order to help keep them in synchronicity with the vent. And so that can actually lead it to where those paralytics work for much longer than you would think. And so when you turn it off, all patient's not moving still, it could be related to the use of one of these drugs. So it's a black box warning there.
Polymyxin B can also be used for when we were doing opto for conjunctivitis. If it got absorbed systemically from that area, are you worried about toxicity?
No, so you really don't see a lot of good systemic absorption through topical use. Even if you have like an open wound, you can apply it there and you don't really see a lot of good absorption. So yeah, so really no concern from topical use causing this. That's a good question. Okay, any questions on the antibiotics? That is almost all of the antibiotics. I'm sure you guys are antibiotic out.
Quick question. So if you don't use vancomycin, that's the first line, right? Your second line would be daptomycin?
No, so if you are trying to treat like an MRSA infection, so say you're worried about like osteomyelitis or something, vancomycin is a good one to go to for empiric therapy, and then depending on what your culture results come back as, you can consider, if it's resistant, then you usually go over to something like linezolid, right? And then depending on the situation, so if it's like an MRSA pneumonia, you're obviously never going to use daptomycin, right? On the other hand, if you are, if it's a bloodstream infection, daptomycin might be a better option to go with. So it just depends on the site. Again, it's one of those things where there's no great black and white answer. It's going to depend a lot on patient factors, the provider you're working with, what their experience has been, what's on the hospital formulary, whether or not you can get it. So for instance, daptomycin, both daptomycin and linezolid are really expensive, but over at Nemours, we really don't have a need for daptomycin because we don't really run into those kind of bugs that often. Because kids are, most of the time they're generally healthy for the most part, so you don't run into those kind of bugs. And so linezolid is our go-to. So it just depends on where you work at, what the kind of factors are. Cool. Any other questions on antibiotics before I move on? Okay, so this section looks kind of bad, antifungals, but it grows on you after a while. Whoa. Yep, anywho. So we have a whole bunch of other drugs that we use for treating fungal infections. And the reason why we have different drugs with different mechanisms is because obviously fungus cells are much different than bacterial cells, much different than mammalian cells. So the big thing that we're going to be focusing on is going to be their cell wall. A lot of the drugs we're going to be using as antifungals are going to affect the cell wall. So notice that they're going to have this, ergosterol is a big component of that. So most of our drugs are going to be targeting things like ergosterol, but they have different ribosomes that we can be targeting. There's a distinct nuclear membrane that's going to be a little bit harder to treat. So we'll see that different drugs are going to have different mechanisms specifically targeted against these fungal cells. So who's more likely to get a fungal infection? Generally, you're going to see patients who are immunocompromised or have had some sort of new introduction of these fungal cells into a site of infection. So if you have like a loss of barriers, so usually your skin's pretty good at preventing a lot of these fungal infections, but if you were to have significant burn injuries, if you were to have surgery, might have exposed you to new exposure to fungal cells, or things like indwelling catheters that could all be at risk. Certainly ET tubes can be a vector for that. Immunodeficiency is also going to be the other big one as well. So, things like cancer, HIV, organ transplants, where they're on a lot of immunosuppressants, chemotherapy, all of that can put you at risk for it. And then other things, things like diabetes. Certainly, if you have, lots of sugar floating around, lots of things that want to grow in that kind of medium. In some cases, if you have a lot of suppression of other competing organisms, so if you have a lot of broad spectrum antibiotics on board, it puts you at risk for developing a fungal infection. So it's not uncommon to see, like in the ICU, where you're treating patients, say for pneumonia, they seem like they're getting better, and all of a sudden they start to get worse, even though nothing's changed with their antibiotics. And then you got to do a fungal culture and see what's going on, and typically it'll come back positive for that. And then also things like moist, warm environments are popular places for funguses to grow. So certainly things like athlete's foot, diaper rash is where a lot of those are going to come into. Most are going to involve the skin, as we'll see, but they can be systemic infections, especially those that have poor immune systems, and it can be very, very difficult to treat. So in a lot of cases, you're having to use very toxic drugs, or you're having to treat for very long periods of time, usually on the scale of months, in order to eradicate some of these infections. So lots of different varieties of bacteria. I'm not going to get super into detail on specific ones, but just know the very common ones include things like Aspergillus, Candida are very important, Cryptococcus, Histoplasma. All these things are potential organisms for causing these infections. And then certainly you see things like microsporum and things like that for more superficial type infections, so where you see hair or nail infections coming from. So the different classes of drugs that we'll talk about are different groups. The first one is going to be the polyenes. This is going to include things like amphotericin B and nystatin. We'll have flucytosine as an individual one here. We'll have the imidazoles, which is including things like ketoconazole. These are probably going to be the more common ones that you're familiar with. You have triazoles, things like fluconazole, echinocandins, griseofulvin, and then some of your alloamines. We'll talk about each of these individually. So again, ones that are working against the cell membrane, we'll talk about those first for the most part. So the ones, the polyenes, they're going to be working by altering the membrane integrity. So they're kind of similar to what we saw with the polymyxins. They're kind of opening up pores within the cell membrane to allow contents to float out and eventually kill the cell. So that's how those drugs are going to work. That's where things like your amphotericin B come in. Your azoles and also your alloamines are actually going to be working through different mechanisms to decrease the amount of ergosterol that's being produced. So if ergosterol is not being made, then it's not going to allow the cell wall to continue to be produced. That's going to cause the fungal cell death. And then also affecting the cell wall are going to be our echinocandins. They're going to be affecting this D-glucans and preventing it from being formed, which again inhibits that cell wall formation. So again, similar mechanisms to what we saw with some of our antibiotics, just working on different targets because the cell is so different. We'll see that some things like griseofulvin are going to work on cell division by inhibiting the activity of the microtubules that actually pull the DNA apart during cell division. And then we'll have some that actually affect nucleic acid synthesis as well. So flucytosine is going to fall into that category. We'll talk more about these in detail. Okay, so amphotericin B is going to be the first one we'll talk about. So this one is going to be, you notice that the structure of here is kind of planar. It looks like a kind of a long, flat kind of structure there. What it's going to do is it's going to basically insert itself into the membrane and kind of open it up, allow this pore to occur. You have oxidative damage to the membranes, allow a lot of potassium and magnesium to leak out of the cell to eventually cause death. So it's a very effective drug, but unfortunately we'll see that specificity for the fungal cells isn't complete, and you're going to see it's going to have some effects on our cells as well. Amphotericin B is very, very toxic, as we'll talk about in a second, and so there's lots of different dosage forms that are available in order to help prevent those from occurring. So for example, there are different lipid formulations that allow for less toxicity to happen. So say for instance, you have this amphotericin B, this liposomal amphotericin B. And so essentially what they've done is they've engineered these lipid bilayer basically spheres that are impregnated with the amphotericin B. And by doing that, it actually prevents a lot of the toxicity that you're going to see causing to the different organs. The other thing, though, it's going to be a lot more expensive. So amphotericin B itself is relatively cheap, but very, very toxic. So we end up using a lot of these more expensive components. It could be up to 50 times more expensive, but because they, dealing with the renal failure the patient might have had otherwise could be probably a lot more expensive than the drug is going to be. It makes good sense to use those. This is going to be able to treat a lot of different invasive fungal infections, so you're really going to be reserving it until you have a patient who has a really significant fungal infection. So this is where your medical ICU patients who have developed these as a nosocomial infection, HIV patients, chemo patients, these are all going to be ones that you'll see amphotericin B being potentially used. Similar to vancomycin, there are issues if you infuse it too quickly. They don't really get a red man syndrome, but they certainly do get a lot of flushing that can occur. You know, there's hypotension that can develop, and so a lot of that's due to histamine release and whatnot. So oftentimes you end up pre-treating patients with things like diphenhydramine, which is an antihistamine, with things like steroids in order to help prevent this from happening. And then you infuse it over 4 hours to prevent that infusion reaction from occurring. It's still going to happen to some degree, and a lot of it's due to things like just those inflammatory mediators being released. You'll also end up seeing a lot of fever and chills, and this is related to things like interleukin-1 and tumor necrosis factor being released as well. So this is where you can use acetaminophen to help deal with some of the fever seen there. The big adverse effects you're going to be looking for whenever administering amphotericin is going to be electrolyte abnormalities. So similar to what you see with the fungal cells releasing potassium and magnesium, same thing kind of happens to us, and you end up wasting a lot of electrolytes, which can be very problematic, especially if you have a patient who's got cardiac issues. They're requiring those electrolytes to maintain a normal rhythm. If you have other drugs that are affecting their electrolytes, that can be a big issue. Hypotension related to that infusion reaction we talked about, and then just damage to the kidneys themselves. So you can end up seeing uremia, and this decreased filtration. So again, it can be a big problem because if your patient's already septic and hypotensive, this can just worsen the renal injury that's happening there. So again, we always pre-treat with medications we talked about, and then also give them lots of saline beforehand because that kind of helps kind of tank them up a little bit, keep the intravascular volume full, so you have less of that hypotension developing there, and hopefully keep the kidneys hydrated. Another one that falls in this category that is not administered systemically is going to be nystatin. This one is, even though you can sometimes see it being used orally, it does not get absorbed from the GI tract. So this is going to be really good for things like oral candidiasis or thrush, and you'll oftentimes see it used topically as well. So like nystatin powder, nystatin cream or ointments and things. And so these are going to have very similar activity, but these are going to be more for like the topical type of infections. That was natamycin we talked about, that one. So similar name, but different drug. So nystatin's usually one of those ones you see where it's like, swish and spit or swish and swallow. Again, it doesn't get absorbed orally, so you don't see a lot of systemic activity from it or side effects or anything like that, which is nice. The next drug we'll talk about is 5-fluorocytosine. This one is not used super commonly that I've seen, but again, this will be used oftentimes for these invasive fungal infections, usually in combination with other things like amphotericin B for things like cryptococcal meningitis, sometimes used with another drug called itraconazole. And so this one is going to be working basically by blocking DNA synthesis within the fungal cell, because it's going to be basically inhibiting this thymidylate synthase and preventing thymidine from being incorporated into the DNA. So you see a lot of antivirals that work on a kind of similar activity as well. We'll talk more about antivirals in the later lecture. Because it's affecting DNA synthesis in the fungal cell and it's not 100% selective for those cells, it affects us as well. And so this is where you can see things like bone marrow suppression, hepatotoxicity, and then GI disturbances and rash. And this one is available oral only. So again, if you're treating a patient who, say, was a hem-onc patient who's receiving active chemotherapy and they're already having bone marrow suppression from that, this could potentially even worsen that even further. So it's another drug interaction to keep in mind. Okay, then moving on, we have our imidazoles and triazoles, and so this is actually interesting because fungal cells have their own version of CYP enzymes, and so these drugs are going to be working to inhibit fungal CYP P450. otherwise known as this 14-alpha demethylase, and it's involved in converting linosterol to ergosterol, which is important for that cell wall to be produced. And so it inhibits that conversion, so there's less ergosterol, less cell wall being made, and lead to the cell death. You can see here it's pretty wide treatment of different types of fungus that they can treat. Usually things that are causing, athlete's foot, ringworm, things like that. These are the main bag where you can see these being used. As you might imagine, because these drugs are inhibiting fungal CYP3A4, and we already said that these are not 100% specific for fungal cells, they're going to affect our CYP3A4 as well. So one of the major drug interactions you're going to be seeing with these fungal drugs is going to be CYP interactions, right? And you guys are all experts on CYP interactions now, right? Absolutely. So some of the big ones you're going to see used fairly commonly include things like ketoconazole. Yeah, I usually see a little bit more frequently topical preparations for ketoconazole, but certainly because you have this CYP3A4 inhibition occurring here, every other drug that's a substrate for CYP3A4 runs the risk of having their levels raised or decreased. Raised, right, because you're inhibiting that enzyme. So you always run that risk of having that drug interaction there. Another one you have here is called itraconazole or Sporanox. This one is, again, going to be more relegated towards infections that are a little bit more invasive, usually used a little bit more systemically. I see this a lot in neutropenic patients, or say post-op or status post-chemo administration and things like that. Again, inhibits CYP3A4, so it's going to be a big interaction you see there. This one's actually also teratogenic, so you want to make sure that patients are not pregnant. But again, hopefully those patients receiving chemo have already had their pregnancy test done and all that. And then we also have posaconazole or Noxafil. Again, very similar instruction to a lot of the other drugs like itraconazole. And again, don't memorize specifically what fungus this is going to be used to treat, because I'm not going to get that into the minutia there. But this one is notable because it will cause QT prolongation. So again, if you had your patient who was very sick and maybe was having was on other antibiotics that also prolong QT, say like a fluoroquinolone, and then you add this on, you're just asking for trouble there. So again, it might be something you say, well, let me check an EKG after administering this drug and see what the QT looks like. If it's prolonged, then you may want to decide to use something else. Yes?
Does this one cause QT prolongation because the hypokalemia part?
It could be related to that, but it's also going to have the interaction on that potassium efflux pump as well. Yeah, but that's certainly a good interaction to point out. That could be exacerbating as well. If you're becoming hypokalemic, that can worsen it. Then a more familiar one, I'm sure most people have heard of diflucan or fluconazole. So this is another good one that has good oral absorption, has good CNS penetration. So it's good for things like cryptococcal meningitis and preventative measures in AIDS patients. Also can be used for things like vaginal candidiasis as a single dose. So oftentimes you see those being dispensed. Keep in mind though, it's also going to have CYP3A4 inhibition. So it's also going to be significant for those drug interactions. We have voriconazole, which is a fluconazole derivative. This one's kind of interesting in that, again, you see a lot of significant CYP interactions here, not just 3A4, but also things like 2C9. So that can be important for things like warfarin metabolism. The interesting thing about this one is that the drug itself is not super soluble. And so in order to get it into an IV formulation, they had to complex it with this cyclodextrin, which is essentially kind of this ring-shaped molecule that has the drug kind of sit in the middle of it that allows it to be solubilized. It's also been explained to me it's very similar to how Febreze works. Febreze covers up nasty smells because it has these cyclodextrins that'll actually just allow the stinky stuff to sit in the middle, and then you don't smell it anymore. So eventually Febreze wears off and you smell it again. For anyone's had like a bachelor pad or anything. Invest in that. Anywho, but the vehicle here, if you have poor renal function, you can actually end up accumulating over time, which the clinical significance that we may not know, but it's kind of an interesting dosage form point to note there. Okay, then you have a lot of topical agents. These are going to be your imidazole derivatives. A lot of these are going to be used for topical purposes only. So certainly things like clotrimazole, miconazole, you can see the brand names here, things like Vagistatin and Lotrimin, things like that. They're very common OTC products. You guys, I'm sure, have heard of many of these before. Moving on, then we have our echinocandins. So these are going to be, again, used for more invasive fungal infections. The ones we see here are going to be caspofungin, mycofungin, and then anidulafungin. Just say Araxis, a little bit easier. These are similarly going to be working on the cell wall, but it's going to be not working on that CYP3A4 to prevent ergosterol formation. Actually prevents this 1,3-beta D-glucan from being formed by inhibiting that synthase enzyme. So we see this used for things like esophageal candidiasis, like really severe infections, and systemic aspergillus. Usually you go to these when everything else has kind of failed for the most part, or you can't use something like amphotericin due to toxicities. These are pretty well tolerated for the most part, but you can still see things like hypokalemia, hypomagnesemia, things like that that can develop as well. One you're probably going to see more in the primary care kind of area is going to be griseofulvin. This is going to be working to prevent fungal cell division by inhibiting those mitotic spindles that are important for pulling the DNA apart when you're having the cell division there. The other thing that's nice about it is it actually gets deposited into keratin precursor, and so it actually ends up depositing into the skin, the hair, and the nails. So as you might imagine, these are going to be really good for kind of topical fungal infections, so things like onychomycosis and things like that. Big thing to note here is the duration of treatment. Right, so if you have a scalp infection, that can be treated in a month. That's pretty long, but okay, we can deal with that. Fingernails, toenails, those are very, very difficult to get because those are kind of distant regions, and it's hard to actually get the drug to the site of action. You have to treat for a very long time. So, patients can barely take drugs for 7 days straight. Imagine taking it for 6 to 9 up to 12 months, right? Very, very difficult. So treatment failures are very common with this, not because the drug's not working, but because oftentimes the patient's not taking it as intended or for the prescribed period of time. It's very lipid soluble, and actually the absorption gets better if you take it with high-fat foods, which is good. And then as far as drug interactions go, it does inhibit some 2C9, so you may have interactions with patients on warfarin, but for the most part it's pretty well tolerated. And I see this a lot. In relatively healthy patients are coming with these nail infections and things like that, so you usually don't worry too much about drug interactions for the most part. We have our allylamine, so this is naphthene and terbinafine. These are going to be working to inhibit ergosterol synthesis by not working on that the CYP enzyme, but more working on the squalene epoxidase. You'll see topically you'll have this naphthene, then oral or topical you have this Lamisil found here. And so if you notice there's a Lamisil on the other side as well, which is a different drug, keep in mind that a lot of OTC products can have different names for the same, or have the same name for different drugs. It's just all kind of marketing. Like if you hear Lamisil, you're kind of thinking one thing, and it could be multiple products that have that same name attached to it. Again, note that treatment is going to be for a pretty prolonged period of time. So again, 6 to 12 weeks, up to 12 months. So toenail infections are very, very prone to failure just due to treatment not going on for a long enough period of time. Then you have your last one you have here is tolnaftate or tinactin. This is going to be working to distort the fungal hyphae and also stunt the actual mycelial growth. You'll see this mainly being used for cutaneous mycoses. This one's going to be topical only, so just kind of know where you can use this and where you can't. Okay, any questions on antifungals? Yes?
Back on, I don't know if I'm saying this right,
Mm-hmm.
you said that it inhibits CYP2C9, which metabolizes warfarin.
Mm-hmm.
So does that mean that patients that are on blood thinners are going to have a higher warfarin level with that drug?
So you run the potential of them having a higher warfarin level, which can lead to more bleeding risk, right? So it's only for, really warfarin's the only drug we use clinically that works as that vitamin K antagonist, and so that's really the main one you'd see with that. Yep. Okay, and then real quick, we'll cover just a couple of antihelminthics because there's really nowhere else that I included this in the material, so I figure I'll cover it now because you may see them out there in kind of the primary care world. Obviously, we're going to be treating some worm infections. This is not an all-encompassing list. So these are the kind of the more common ones that I see. So you have these benzimidazoles. So this will include things like albendazole and mebendazole. These are going to be working by actually working on those helminth microtubules. It can also work on glucose uptake, so eventually lead to parasitic death via these kind of two different mechanisms here. Pretty wide range. You can use them for things like hookworms, roundworms, pinworms, all of those. The They're pretty well tolerated for the most part, but you do run the risk rarely of having hypersensitivities and rashes, which can include up to Stevens-Johnson syndrome and TEN. And then you also have pyrantel or Pinax is another somewhat common one. This one is going to actually be working via a different mechanism where this actually releases acetylcholine and actually inhibits cholinesterase. So cholinesterase is an enzyme that is responsible for metabolizing acetylcholine. So you have way too much acetylcholine around, and it's going to be affecting what kind of receptors are affecting muscle. I guess what type of acetylcholine receptors are on the muscles? Not muscarinic. Yeah, it's your nicotinic receptor, right? Those are on the skeletal muscles that are responsible for causing the activation. So when you have overstimulation of those nicotinic receptors, it eventually leads to paralysis. We have drugs that work on people that do that, but this is going to work specifically on the worms in order to cause paralysis. So it's more specific for them, which is good because you don't want it to happen to us, because otherwise that would lead us to be paralyzed. This one's going to be useful for pinworms and hookworms. Again, pretty well tolerated, and they have some GI upset. So those are kind of the main ones you see used as far as worms go. There may be some other ones that pop up randomly. Any questions on the ID section? All right, I'm gonna let you guys go now, but I'm really gonna have to hustle through the ENT stuff the next time, so we can be done before the test. So just be aware, it's gonna be a hot and heavy one next time. Okay. Is there anything else before we go? Yes.
Did you say you do a review before the test, or?
I will try to fit in a review, but since I kind of went over and I was long-winded on the IED stuff, we'll see how that works out. Yes?
How much do you want us to concentrate on
Shh, what's that, guys?
on the specific amounts for dosages, unless it's like a really important, like super toxic drug for antibiotics?
I'm not really going to focus on dosing whatsoever. So I'm not going to expect you guys to know that this drug is dosed 600 milligrams every 6 hours. Right. I may ask you, why do you think this drug is dosed every 6 hours? And it might be because it's a time-dependent killer, right?
Okay.
Yep.